Infarction is an area of ischemic necrosis caused by occlusion of the vascular supply to the affected tissue. The process by which such lesions form, termed infarction, is a common and extremely important cause of clinical illness. Roughly 40% of all deaths in the United States are a consequence of cardiovascular disease, with most of these deaths stemming from myocardial or cerebral infarction. Pulmonary infarction is a common clinical complication. Bowel infarction often is fatal, and ischemic necrosis of distal extremities, gangrene, and ischemic necrosis of distal causes substantial morbidity in the diabetic population. Arterial thrombosis or arterial embolism underlies the vast majority of infarctions. Infarctions are classified on the basis of their color, depending on the amount of hemorrhage and the presence or absence of microbial infection. Those infarctions may be either red or hemorrhagic, or white or anemic, and may be either septic or bland. Red infarction occurs with venous occlusions such as an ovarian torsion, in loose tissues, for example lung, where blood can collect in infarcted zones, in tissues with dual circulation, such as lung and small intestine, where partial inadequate perfusion by collateral arterial supplies is quite typical. In previously congested tissues, as a consequence of sluggish venous outflow, and when flow is reestablished after infarction has occurred, for example, after angioplasty or an arterial obstruction. White infarcts occur with arterial occlusions in solid organs with end arterial circulations, like in heart, spleen, and kidney, and where tissue density limits the seepage of blood from adjoining patent vascular beds. Infarcts tend to be wedge-shaped, with the occluded vessels at the apex and the organ periphery forming the base. When the base is a serosal surface, there is often an overlying fibrinous exudate. Lateral margins may be irregular, reflecting flow from adjacent vessels. The margins of acute infarcts typically are indistinct and slightly hemorrhagic. With time, the edges become better defined by a narrow rim of hyperemia attributable to inflammation. Infarcts resulting from arterial occlusion in organs without a dual circulation typically become progressively paler and sharply defined with time. Hemorrhagic infarcts are the rule in the lung and other spongy organs. Extravasated red cells in hemorrhagic infarcts are phagocytized by macrophages, and the heme iron is converted to intracellular hemosiderin. Small amounts do not impart any appreciable color to the tissue, but extensive hemorrhages leave a firm brown residue. In most tissues, the main histological finding associated with infarcts is ischemic coagulative necrosis. An inflammatory response begins to develop along the margins of infarction within a few hours and usually is well defined within 1 to 2 days. Eventually, the inflammation is followed by repair, beginning in the preserved margins. In some tissues, parenchymal regeneration can occur at the periphery of the infarction where the underlying stromal architecture has been spared. Most infarcts, however, are ultimately replaced by scar. The brain is an exception to these generalizations. Ischemic tissue injury in the central nervous system results in the liquefactive necrosis. The effects of vascular occlusion range from inconsequential to tissue necrosis leading to organ dysfunction and sometimes death. The range of outcomes is influenced by the anatomy of the vascular supply, the time over which the occlusion develops, the intrinsic vulnerability of the affected tissue to ischemic injury, the blood oxygen content. The presence or absence of an alternative blood supply is the most important factor in determining whether occlusion of an individual vessel causes damage. The dual supply of the lung by the pulmonary and bronchial arteries means that obstruction of the pulmonary arterioles does not cause lung infarction unless the bronchial circulation also is compromised. Similarly, the liver, which receives blood from the hepatic artery and the portal vein, and the hand and forearm, with its parallel radial and ulnar arterial supply, are resistant to infarction. By contrast, the kidney and the spleen both have end-arterial circulations, and arterial obstruction generally leads to infarction in these tissues. Slowly developing occlusions are less likely to cause infarction because they allow time for the development of collateral blood supplies. For example, small interarterial anastomoses, which normally carry minimal blood flow, interconnect the three major coronary arteries. If one coronary artery is slowly occluded by an encroaching atherosclerotic plaque, flow in this collateral circulation may increase sufficiently to prevent infarction, even if the original artery becomes completely occluded. Neurons undergo irreversible damage when deprived of the air supply for only 3 to 4 minutes. Myocardial cells, although hardier than neurons, still die after only 20 to 30 minutes of ischemia. By contrast, fibroblasts within myocardium remain viable after many hours of ischemia. Understandably, abnormally low blood oxygen content, regardless of course, increases both the likelihood and extent of infarction. This is the end of our discussion today. Thank you for your attention.